anyone know what's likely to be damaged in a hysterectomy? Ureter. That's your, because you have to ligate the uterine artery, and then the ureter is right under it. Okay, just remember, ureter most likely to be damaged hysterectomy. And that's, did he or she talk about photosynthesis? Okay, just remember the pouch of Douglas is the accumulation of fluid when you're sitting in the upright position. And I believe that's it for that one. And then for the male, it's going to be something about the corpus cavernosum and spongiosum. So spongiosum, just think opposite. When you think of a sponge, you think of it like absorbing blood, but it's opposite of that. So instead of was it holding the blood, it's just going to have the ureter. And then the cavernosum won't have the blood. And the thing about the prostate, so let's see. So what's important to know is that prostate cancer is only in the periphery or the posterior part. Okay, so you do that for the digital rectal exam. But for this one, the transitional zone, the one in the center, notice how it's close to the ureter? Or was it urethra? That's for BPH. So BPH is trouble with peeing. Prostate cancer is the digital rectal exam. And for erection and ejaculation, just remember point and shoot. So point, erection, parasympathetic, and then shooting, sympathetic. Okay, any questions? I moved through that really quick because that's anatomy. Any questions before I move on? Okay. I'm going through Meisenberg's lectures. I don't want to go through Wilson's lectures, so. Okay. So what you need to understand is that the bumpy coat has your platelets and white blood cells. Sorry, do you have a question? Oh, no, okay. So just know that the bumpy coat will have your platelets, the white blood cells, and, okay. Okay, whatever. And then for the plasma, what is it, protein electrophoresis, just look at your hand, do this, this is plasma, this is your electrophoresis. So your pinky is albumin, and then your thumb is your gamma globulins. You can kind of see it, right? Okay, cool. Just remember, albumin should be the highest, and gamma should be the broadest. And also know that alpha 2 has the largest protein size. Yeah, and alpha 1, if you see alpha 1, just remember emphysema for alpha 1. Okay, I'm just gonna move on. So for albumin, just know that its main function is to reabsorb water. So if you're low in albumin, you can't reabsorb water back into your bloodstream, so you get edema. Oh, and in a healthy person, you want the colloid osmotic pressure to be the highest. Okay, so for this disease, hypoalbuminemia, so it's in the name, so there's low albumin, and remember when you have low albumin, you do not have the oncotic pressure, and without that oncotic pressure, you'll get edema. And just know that the liver makes albumin, so if your liver fails, you cannot make out. And then the other condition you have to know is nephrotic syndrome, and just know that this syndrome, you're peeing out proteins.
What?
But you're peeing proteins in nephrotic. Whatever. Okay, so haptoglobin and hemopexin. What you need to know about hemopexin is that it binds heme, so that's the inorganic portion of hemoglobin, and haptoglobin binds the proteins. And you only measure free haptoglobin and hemoglobin. So if the question says that you see a decrease in haptoglobin, what does that mean? And it means the person just had a recent bleeding. If you see that there's a decreased haptoglobin, what does that mean? It means that person had a bleed or something. Because you're only measuring the free haptoglobin and hemoglobin. Did you learn about sickle cell yet? Sickle cell? All right. Let's see. You need to know this. Okay. Just know that alpha 1 is your anti-proteases, and alpha 2 are your large proteins. Okay. Any questions before I move on? Okay, so if you see alpha 1 antitrypsin deficiency, just know lung emphysema. I can't hear you. Alpha 1, yeah. Yeah, so he asked what would be the effect of haptoglobin when someone had a recent bleed, and it would decrease. Because you're only measuring free haptoglobin, and when the function of haptoglobin is defined, broken down in blood cells. Yeah. Okay, so alpha 1 antitrypsin deficiency and lung emphysema. Hold on. I'm just telling you too much detail, but emphysema is an inflammatory condition, and in inflammatory conditions, it's a balance between inflammation and anti-inflammation. So for alpha 1 antitrypsin deficiency, you have a deficiency in the anti-inflammatory proteins. And then the reason why you get cirrhosis is because you're not able to release the antitrypsin. Does that make sense to everyone? Okay.
So the alpha 1 antitrypsins are
Anti-inflammatory or anti-protease. Okay. That's a better way to say it. They're breaking down they're breaking down proteins that cause emphysema. Okay. It's an anti-protease. Anti-protease. Yeah, so if you have an infection, you won't be able to turn off your inflammatory cells, so that will worsen the emphysema. Okay, so immunoglobulin, just know that's made by platelets, not platelets, plasma cells, and it's in the gamma thing, it's your thumb. Okay, M spikes, this is what it looks like, don't worry about it for now. And if you see this, just know that it's a lot of immunoglobulins. But, yeah, okay. But really the questions are going to be about this. So being able to read it, so this is the thing where your hand comes in. Where should I start? So the first one, acute phase, so think of like you're having a fever. So remember, albumin is made by the liver. Your liver shuts off albumin production to make more of your other proteins. Okay, liver shuts down albumin to make more of other proteins. Nephrotic syndrome, you're losing proteins. Just remember, alpha 2 are your large proteins, and those will not be lost because they're so big. That's why it'll get increased. And then liver cirrhosis, Again, so no albumin. Yeah, just remember low albumin and increase in alpha 2 and increase in gamma globulins, just because it's a chronic inflammation. Okay. Nephrotic, because gamma globulins are proteins, so you're still losing proteins in nephrotic. They're small proteins that you're using. Huh? Yeah, because it's a small protein, yeah. Any questions about this? Do you have these slides? Do you have this picture of this? Okay, just pretty much just remember that. Whatever. Do you have this slide? The treatments for these things when you use them. Okay, let's get that. No. That's for the. I'll get to that. Whatever. Okay, alkaline phosphatase. Okay, so these things. Alkaline phosphatase. Just notice with the B's, so bones and biliary. So with the B's. And then to differentiate it between bone and biliary, you do a GGT. And then look at, so there's like green, G, this is the G1. So green, think of gallbladder, and then GGT. So all the G's are with GGT. And think of gallbladder when you see this. So if you see elevated alkaline phosphatase and elevated GGT, then it's a gallbladder problem. If you see elevated alkaline phosphatase but normal GGT, it's a bone problem. Okay. Any questions about that? Okay, and then same concept for acid and PSA. So if it's a problem with your blood, ASP is increased, but PSA is normal. If it's with your prostate, PSA is increased and acid is increased. And don't get acid and alkaline mixed up. Okay. Okay, so amylase and lipase, just know it's pancreatitis, straightforward. Creatine kinase, anything to do with muscle. And then these you have to know, CK1, 2, and 3. Know what they are, CK1, 2, and 3. Just know where you find them. And then the same thing for LDH. You know the isoenzymes and where you find them. Yeah, you don't worry about that. But she could also give you something like this to read off of it as well. Okay, any questions? Okay, I'm gonna move on. Oh wait, there's one more. Hemoglobin, myoglobin. It's the same thing. Same thing with the hand, but it's just, if it's darker, like this one, you can see more, it's increased. If it's paler, yeah. Oh, but keep in mind this is the urine. This is urine, not plasma. Because if it's urine, you have to think the opposite. Does that make sense? Because there's a difference between serum and urine. So urine is what you're excreting, serum is what's in your blood. So make sure you to like be able to flip-flop between urine and blood. Any questions? Okay. Clotting. Hold on. Let's see. They do a bad job of teaching this, but this is your clotting cascade. Okay. So just remember, common pathway starts at 10, and the goal is, so the goal is to count to 10. So the intrinsic pathway goes to 12, 11, the goal is 10, so you skip that, so it's 9 and 8. So that's intrinsic. And the test for the intrinsic pathway is PTT. So it has more, more numbers, so the test will have more letters. And then just remember the extrinsic pathway is just 7, and it's PT. And then to correlate with the test, PTT has 3 things, and what activates it is subendothelial collagen. And then what activates the extrinsic pathway is tissue factor. And notice how there's two letters with two tests, or with a two-letter test. But what's important to know is that PTT is for the intrinsic pathway, PT is the extrinsic pathway. Okay. And then for the common pathway, so if you have a defect in your common pathway, you'll have elevations in both PTT and PT. And just know that factor 2 is thrombin, factor 1 is fibrinogen. Okay, any question about the clotting cascade? Okay, anyone need more time?
What is
SEC is subendothelial collagen. Okay. Okay, I'm gonna start from the beginning. That was the beginning. Okay. Okay, so there are two parts of the clotting pathway. The primary part is for your platelet plug. Secondary pathway is your coagulation factors. Just keep in mind that the test for the primary or the platelet is bleeding time, and the test for the coagulation cascade is PTT and PT. So if you have a defect in the coagulation cascade, your bleeding time will still be normal. But if you have a defect in platelets, bleeding time will be affected, but the PTE and PTT will be unaffected. Okay, so for the primary platelets, and that's tested by bleeding time, then the secondary clotting is the coagulation cascade, and that's tested by PT and PTT. Whatever. What's this? Nope. Okay. Prostacyclin increases cyclic AMP and it inhibits platelets. And just know that thromboxane activates platelets. And just know that, thromboxane is inhibited by aspirin. So if you give someone aspirin, you're inhibiting their platelets, and then their bleeding time will be increased. Prostacyclin increases cyclic AMP to inhibit platelets. And if you didn't get what I said, aspirin increases bleeding time. Yeah. Thromboxane increases calcium. Cool. Okay. Let's see, what's this? Okay, so it's not important. Okay, I guess just know that collagen binds to GP1B, and that the disease with GP1B is Bernard-Soulier. Okay, and then GP2B3A binds to fibrinogen, and the deficiency in that is Glanzmann thrombasthenia. Okay. Collagen, GP1B, Bernard-Soulier, GP2B3A, fibrinogen, Glanzmann thrombasthenia. Okay, whatever. What's this? Nope. Okay, what is this? Thrombocytopenia. It's straightforward. Thrombocytopenia, decreased platelets, so your platelet count will be decreased, but bleeding time will be increased. Thrombocytopathy, platelet count will be normal or elevated, but bleeding time will be increased. What's this? Factor 13 and calcium make a stronger clot. thrombin makes fibrin. Did you talk about gamma carboxyglutamate? She said yeah? Okay, just know that this is what is this again? This is just where, this is the thing you cleave to activate the things, activate the clotting factors. Gamma carboxyglutamate is what you cleave to activate clotting factors. Okay. Okay, and just know 2, 7, 9, and 10 for the factors that need vitamin K. 2, 7, 9, and 10. And then just know that warfarin inhibits the synthesis of 2, 7, 9, and 10. So remember the magic numbers for first semester 7, 9, and 10. So just add a 2 in front of it. 2, 7, 9, and 10 needs vitamin K. Warfarin inhibits vitamin K. So if you give someone warfarin, you'll be deficient in 2, 7, 9, and 10. Did I lose anyone? Okay, I'm just gonna move on. Thrombomodulin. Just know that thrombomodulin activates protein C. Protein C activates, inactivates factors 5 and 8. Factor 5 lead-in, you have a factor 5 that cannot be inactivated, so you're hypercoagulable. Okay, so just know that TPA, urokinase, and streptokinase activate plasmin. TPA, urokinase, streptokinase. And then what plasmin does is that it breaks down fibrin to break down the clot. And when we break down fibrin, you have an elevation of D-dimers. So TAP, urokinase, streptokinase make plasmin. Plasmin cleaves fibrin, and when you cleave fibrin, you have an elevation of D-dimers. Okay, so you have to know that antithrombin 3 is activated by heparin, and antithrombin 3 inactivates factor 2 and factor 10. 2 and 10. Oh, and just know that heparin is found in mast cells and endothelial cells. Okay, I already talked about that. Oh, and the difference between warfarin and heparin. Warfarin, you're inhibiting the synthesis of clotting factors. Heparin, you're directly inactivating clotting factors. Therefore, because heparin inactivates it directly, it's used for emergencies. Whereas warfarin, because you're inhibiting the synthesis of something, will take a longer time to stay in effect. Yeah, so warfarin, you're affecting the synthesis of clotting factors, so the effects take longer. And then heparin, you're directly inactivating factors, so the effects are more immediate. Any more questions? Okay, so hemophilia A, instead of A, just say 8. Hemophilia 8. And then just remember, hemophilia B9, because you're learning about folate, so B9. And just know because 9 and 8 are in the intrinsic pathway, so these people will have an increase in PTT. And then if you ever see in the question stem increased bleeding time and increased PTT, you could immediately assume it's von Willebrand disease. Because what von Willebrand does is that it binds to factor 8 and stabilizes it, and it also binds to platelets. Okay, any questions on this? and then yang. Cool. You had this lecture, right? Blood histology. Yeah. Whatever. Just know the difference between serum and plasma. So, serum has no blood, or sorry, serum has clotted blood or no fibrinogen. Okay. And just be able to identify the type of leukocytes because they'll be in the intertraces. Okay. And just know right stain for blood smear. Okay, xerophilic granules. Just know that xerophilic granules are lysosomes. Xerophilic granules, lysosomes. Just know for hematocrit, just know that it's the water volume of blood, and just know that it increases when you're dehydrated. EPO, erythropoietin makes red blood cells. Okay. They have a lifespan of 120 days. And their main source of energy is from glucose. Do you need to know this? Just know anisocytosis, variation in size of the red blood cells. Just know actin and spectrin are deficient in hereditary spherocytosis. So if you see no central pallor, it's hereditary spherocytosis. Okay, so just know what are the granulocytes and what are the agranulocytes. Okay, what is this? Okay, so neutrophils, their specific granule is myeloperoxidase. Eosinophils, it's major basic protein. And basophils are heparin and histamine. Okay, make sure you remember this. Neutrophils, myeloperoxidase, eosinophils, major basic protein, and basophils, heparin and histamine. And just know that basophils are in your blood, so if you have release of histamine, you'll cause anaphylaxis. So the causing cell of anaphylaxis is basophil, not mast cell or eosinophil. It's basophil. Okay, so bacterial infection, neutrophils go up, parasitic, eosinophil goes up. Cool. Whatever. Oh, and just know that, what was it? Do you know about margination in diabetes? Okay, just know that that occurs at the post-capillary venule. Margination in diabetes occurs at the post-capillary venule. Because in the arteries, the blood flows too fast, and in the veins, the blood moves slow, so it's easier for the white blood cells to move across the endothelial cells. Okay. Sepsis is a release of cytokines in the bloodstream. Sepsis release of cytokines in the bloodstream. Okay, let's see, eosinophil granules, talk about that. Okay. Just know NADPH oxidase makes superoxide and hydrogen peroxide. And if you're deficient in NADPH oxidase, we will get chronic granulomatous disease. Whereas if you're deficient in myeloperoxidase, you're perfectly fine. So deficient NADPH and deficiency in NADPH oxidase, chronic granulomatosis disease. Deficiency in myeloperoxidase, you're perfectly fine. Oh, and for NETs, just know that increased chance of autoimmune reactions. NETs, autoimmune reactions. And just know what major basic protein looks like. So it's, think of major basic and think of pink, as a basic pink. Whatever, what is this? Oh. Basophils, anaphylaxis. Monocytes, they have their kidney bean and they turn into macrophages. And just know that they are also antigen-presenting cells. Okay. Then lymphocytes, yeah, that's what they look like. And then this is what a plasma cell looks like, and just plasma cells just make antibodies. Okay, so megakaryocytes make platelets, and just know that this is the only cell that remains in the bone marrow. Whatever. Any questions about the lecture? Okay. Iron metabolism. Basically, to make blood, you need iron. And just know in the 2+ state is the state where iron can cross membranes, and the 3+ state is when iron is stored. So 2+ when it crosses membranes, 3+ is when it's stored. Because remember, in the 2+ state, you get formation of free radicals, so your body doesn't want that, so it puts it in the 3+ state. Whatever. Okay, what's this? Nope. Nope. Oh, and for iron, there's no way to get rid of iron. There's no way for your body to excrete iron. The only way it controls your levels of iron is to either use it by making blood or to decrease the absorption of it. And then for this one, just know that protoporphyrin 9, what was it again? It makes up this entire molecule right here. This is protoporphyrin 9. Yeah, okay. And you need, what was that? Protoporphyrin plus iron make up heme. Protoporphyrin and iron make up heme. Heme degradation. Oh, heme degradation only occurs in your spleen or liver. Did I talk to you about extravascular and intravascular hemolysis yet? Well, you're gonna have to know it, but extravascular hemolysis is hemolysis in the spleen and liver, and intravascular is just in the blood vessels. Well, what's important about those two is that extravascular can cause jaundice. Intravascular just causes, you're peeing blood. Let's see. Okay. Hold on, wait. Is this the right lecture? Oh, wait, shit. I did the wrong lecture. Hold on. I did Meisenberg's lecture. Let me start over. Excuse me. Okay. If you're deficient in iron, you get microcytic. If you're deficient in B12 and B9, you're macrocytic. Whatever. We talked about that. Oh, and what is it? The main absorption channel for iron is DMT1. And to increase the absorption of iron, you give them vitamin C. So vitamin C turns iron from the Fe3+ state to the Fe2+ state. So remember methylglobinemia. So when someone has methylglobinemia, so instead of the 2+ state, hemoglobin is 3+. If someone has methylglobinemia, you give them vitamin C. Oh, and then if you see vegan in the question, the deficiency is in B12. Which part? Which one? Oh yeah. So DMT1 is the main absorption channel for iron, and this is in the duodenum. DMT1 duodenum. And to absorb iron, remember, it has to be in the 2+ state. So you give them vitamin C to help it turn from the 3+ state to the 2+ state. And just to tie the concept of methylglobinemia, so when your hemoglobin's iron is in the 3+ state, that just means that it can't carry oxygen. So you have to turn it back into the 2+ state. You give them vitamin C to turn the iron to the 2+ state. Okay. And if you see vegans, it's B12 deficiency. Okay. And if in the question you see periods, pregnant women, or growing children, iron deficiency. Periods, pregnant women, growing children, iron deficiency. Okay. So remember I talked about the storage forms of iron in the 3+ state. So in the blood, it's called transferrin, and in like the cells, it's called ferritin. And if there's too much ferritin, it turns into hemosiderin. Okay. So in the cells, it's ferritin, and if there's too much ferritin, it turns into hemosiderin. Okay. Whatever. So DMT1 absorbs iron in your intestine. Let's see, and ferroportin releases iron from your intestine to your blood. Just know that transferrin is also called TIBC. TIBC is also known as transferrin. Make sure you know that. What is this? Okay, cool. Oh, and if you ever see decreased ferritin, it's iron deficiency anemia. Anemia. Okay, IRPs, whatever. Yeah, so if you have low iron, your IRPs activate, and then you make more transferrin. So this is why in iron deficiency anemia, you have a high TIBC. And then just think of the opposite of that for when your iron is high. Any questions so far? Yeah, you have high transferrin in iron deficiency anemia. Okay, so hepcidin, just know that this is what turns off DMT1. And then this is what gets activated by anemia of chronic disease. Did he talk about anemia of chronic disease? Okay, so in anemia of chronic disease, remember you need iron. Bacteria need iron to grow. So if you hold in iron, you're inhibiting bacteria to grow. And to do that, your body releases hepcidin to turn off iron absorption, and to also cause your macrophages to sequester iron to decrease the access of bacteria for iron. Yeah. So when you have like a chronic inflammatory condition, what your body does is sequester iron to prevent like any bugs and bacteria to use that iron to grow. And to do that, it secretes hepcidin. And what hepcidin does, it turns off DMT1 to decrease absorption, and it also causes your macrophages to sequester iron. Yeah. And then the caveat with that is that because you're sequestering iron, you're also not using it. So that's why they will also get, what was it, microcytic anemia. Okay, does anyone need me to repeat that? Okay, so let's say you have like a chronic bacterial infection. Bacteria need iron to grow, so what your body does to counteract that is to sequester iron. And to do that, it decreases the absorption and causes your macrophages to hold onto the iron. And that's done through hepcidin, and yeah, hepcidin turns off DMT1. And then the reason why I'm going with this is that the disease hemochromatosis, hepcidin, these people do not have hepcidin. So they're not able to turn off iron absorption. So they will have very high iron levels. Because remember, you can't excrete iron. The only way to decrease levels of it is to decrease the absorption. Okay, any more questions? To treat someone with hemochromatosis, you do phlebotomy, and the reason why you do that is because you're letting blood out, so you have to remake blood, and to remake blood, you need iron. Okay, I already talked about that. Yeah. Nope. And just know this mutation C2A2Y HFE for hemochromatosis. Oh, and if you ever see bronze skin, think of hemochromatosis. Bronze colored skin. Yeah, so because they can't turn off iron absorption, they bleed them to, because iron's also in your blood, so you're also letting blood out and also using up iron. Sorry, you're letting iron out while also using iron to make more red blood cells. Okay. Any more questions? Okay. Okay. Okay, just know that UDP, glucuronidyltransferase, conjugates bilirubin to make it water soluble so that it can be secreted into bile. UDP, glucuronidyltransferase, conjugates bile. Right, it conjugates bilirubin, excuse me. Don't worry about these channels. Just know that, what was it? If you're deficient in these channels, you will have an increase in conjugated bilirubin. Okay, but if you're deficient in the glucuronidyltransferase, you will have an increase in unconjugated bilirubin. Does this make sense? So if you're deficient in this enzyme, UDP, you will have an increase in unconjugated bilirubin. And I forgot to mention that jaundice is caused by unconjugated bilirubin. Make sure you know that. Jaundice, unconjugated bilirubin. And then if you have a missing channel, you'll have an elevation in conjugated bilirubin. So missing enzyme, unconjugated bilirubin, missing channel, conjugated bilirubin. And then heme could be either excreted in your bile, which goes to your poop, or into your urine. Heme is excreted into your bile, which goes to poop, or it could go to your urine. Okay. Oh, and then it's called stercobilin if it's in your poop, and urobilin if it's in your urine. And if you see this picture, they will have two answer choices. It will be jaundice or scleroicterus. The answer is scleroicterus. Does this make sense? Jaundice is like the yellowing of skin. Scleroicterus is yellowing of your eyes. So yeah, that's a better name for it. Oh, and what is it? Unconjugated is the same thing as indirect. Okay, so folates, not important. Okay, just know that the product of just know 5-10N methylene THF. 5-10N methylene THF, I don't know why I circled that, but just know this for some reason. I think this is like the starting point, not the starting point. It's a product, yeah, it's the product of the reaction. 5-10N methylene THF. Okay, you need B12 to remake B9. B12 remakes B9. And B12 is I can't pronounce it, because whatever, B12 is that thing, and B9 is folates. Cyanocobalamin something. Okay. And just know that methotrexate inhibits DHFR. Okay, so the ways you could have B12 deficiency, just remember it takes years to develop this deficiency, and they will present with neurological symptoms. So B12 presents with neurological symptoms, and it takes years to develop. And if you see vegan, just think B12 or iron deficiency. Then I just wanted to compare that with B9. B9, it's shorter to develop, and there's no neurological symptoms. Oh, and just know that B12 has elevations in both homocysteine and methylmalonic acid, and the methylmalonic acid is the one that does stuff with your nervous system. And B9 is just an elevation in homocysteine, but there's no change in methylmalonic acid. Okay. Oh, and pernicious anemia. So you can't, for pernicious anemia, you can't make intrinsic factor, and for intrinsic factor, it aids in the absorption of B12. So if you can't absorb B12, you will get this thing, megaloblastic anemia. And just know that parietal cells make intrinsic factor. Whatever. And just know that it's absorbed in the terminal ileum. Cobalamin. Terminal ileum. Oh yeah, that was it. Any questions about this lecture? Okay. Did you have the hematopoiesis lecture? Oh god. Okay, so you need to know that bone marrow has this continuous lamina. just for this one, the states of the red blood cells. Why did I circle protobus? Okay, something about. Okay, so basophilic erythroblasts is the start of hemoglobin synthesis. And reticulocyte, just know that it has ribosomes. Remember HIFS? Oh, yeah, you already know it. Honestly, for the CFUs, it's in the name of what they make, so don't worry about it. Just know the special one, so CFUGM makes both macrophages and neutrophils. And for the rest, it's straightforward. It's in the name of what they make. Okay. And then for the white blood cells, the promyelocyte is when you see azurophilic granules, and the myelocyte is when you start seeing the specific granules. Oh, and because of the myelocyte, you have the specific granules, that's when you can start differentiating what cell is what. If you see an increase in band or staph cells, it's a sign of an infection. It's called a left shift. Okay. Whatever. Leukemias, just know that they're in the bone marrow, and it's a cancer involving your precursors, and just know that this is always metastatic. Leukemias are always metastatic. Okay, megakaryocytes, they break parts of their own cells to make platelets. Okay. We're good. Okay. Just remember, heme is made from protoporphyrin 9 and higher. Hemoglobin binds 4 oxygen, myoglobin binds 1 oxygen. Myoglobin is in muscle, hemoglobin is in your bloodstream. So myoglobin is just, one is a tertiary amino acid, whereas hemoglobin is 4 myoglobin molecules. All right. Okay. Just know myoglobin, since you're combine 1 oxygen, it's hyperbolic, and hemoglobin is not sigmoidal. So when hemoglobin is tense, it favors oxygen release. When hemoglobin is relaxed, it favors oxygen grabbing. Just know that 2,3-BPG, what is it doing? It decreases the affinity for hemoglobin, so it favors the release. And just know that fetal hemoglobin does not have 2,3-BPG, therefore it has an increased affinity for oxygen. Okay, so 2,3-BPG decreases affinity for oxygen. And just know that fetal hemoglobin does not have binding for 2,3-BPG. And just know that it only binds to beta chains. just remember, if you have, no, there's a, okay. Really, this entire lecture is going to be about, so then the motto for this is that the cadet turns right. So for the cadet, increase in entry in cadet will cause a right shift. So C stands for CO2, A stands for acid, so hydrogen, D stands for dye, so 2,3 BPG, E stands for exercise, and T is temperature. So an increase in anything in cadet will cause a right shift. And just know that fetal hemoglobin and lead will cause a left shift. Fetal hemoglobin and lead will cause a left shift.
Fetal hemoglobin is what?
Lead. Lead. Yeah. Oh, and a sickle crisis will cause a right shift. You're gonna learn about it later. Sickle crisis, the right shift. Sickling crisis, you're gonna learn about later, but just keep this in mind. Sickle crisis, right shift. Okay, any questions about this? Okay. So if iron is bound to CO2, it decreases the affinity for hemoglobin. Okay. Carbon monoxide increases the affinity for hemoglobin, increases the affinity for oxygen. Excuse me. And also just know that cytochrome C oxidase also has oxygen. And let's go to your next question. Oh, and then when someone has carbon monoxide poisoning, did you talk about cherry red skin? No cherry red skin. Okay, just carbon monoxide poisoning. Man in burning building, you give them hyperbaric oxygen. Man in burning building, oxygen. Hyperbaric oxygen. And yeah, just know this one, it raises oxygen affinity. Lead. Or, sorry, did I say lead? I meant carbon monoxide, not lead. Sorry. Yeah.
What was the other one besides?
So the things that cause left shifts are carbon monoxide and, what was it again? Fetal hemoglobin. Excuse me. And carbon monoxide combined to it. I said that was one of my questions, so. Yeah. Okay. Okay, so and then one more thing, the methylglobin. So instead of the 2+ state, it's a 3+ state. And just know that in 3+ state, you can't bind oxygen, so your hemoglobin's useless. And to do that, you give them, don't worry about it, it's not written down. Just know that enzyme that prevents this is methylglobin reductase, or they can take it in oxidizing drug. Okay? So if they're deficient in methylglobin reductase, or if they took a drug that oxidizes iron. Okay, any questions about this lecture? You'll get methylglobinemia. Yeah. What is this? Development of. Okay. You got this lecture, right? The embryo. Crash lecture. Behavioral collapse, because it's really quick. I'll tell you behavioral.
Yeah.
Yeah, it's really quick. That's fine. I'm saving it for last.
Oh, okay.
Okay. Let's see. SRY has TDF. Wait, SRY is on the Y gene that has TDF, and TDF makes you a male. So Y chromosome has SRY, which makes TDF. Okay. I really hate this lecture. It's pretty much this entire lecture is what structure turns into what in the adults. And that's in the last slide. So I'm just going to go to it. Hold on. Right. Am I missing anything? Yeah, it's literally this slide. And they like this question, hold on, they like this question, they ask about the vestigial structure in the male will turn into what structure in the female? So they like that question. So vestigial structures in the male will turn into what structure in the female, and then they could switch it up. Okay. And the vestigial structures in the female is the e-peron, so just think of the poop, and Gardner's duct, and the vestigial structures in the male are the testicular appendix and prostatic utricle, and yeah, this is what they turn into. So that's a guaranteed question in your mini. And another question will be like, it'll be the bolded stuff that she bolds, and I'll ask you what does this turn into in the adult. Okay, any questions?
What was that second thing you said, Keno?
It'll be whatever she bolded, and just know what it turns into in the adults. So this slide. But I know there's some structures that are not on there, so you have to go through that lecture. Okay, what was it? There. Okay, so for this lecture, substance abuse, just know cage, just know what they are, and just know that one, positive is a risk, and two is they have substance abuse disorder. Okay, and then know the chronic and what's the chronic and the other risk? Chronic and acute risk, know what they are, and then the protective factors. Let's see. And just know the rating of the substance abuse. So the 2 to 3 is mild, 4 to 5 is moderate, 6 plus is severe, and then something about stages of contemplation. Yeah. And know that for this one, the classes of substance use. I think there's a slide for it. I'll show you. They got a slide. You have to know what is in each of these categories. So just know the slide, and then know what bullet point is in what. If it talks about a truck driver taking meth, it's risky use. Truck driver taking meth, answers risky use. And then diabetes criteria, just know it. Cage, yeah. Okay, yeah, that was it. I think that's for suicide. That's the wrong lecture. Okay, this lecture. Yeah, just know what's the chronic and static risk. So what's in chronic, what's in chronic and what's in acute. It's pretty much this lecture. So chronic you could change, there's chronic you cannot change, but acute you could change. And just know what are the protective factors, and if you see in the vignette that they have protective factors, the answer is monitor and document. Monitor and document. If you see protective factors, the answer is monitor and document. Oh, and something, what's this? And if it's not monitor and document, you ask them, have you thought about hurting yourself? Yeah. Hold on, no. Actually, no, don't worry about that. The questions, the answer is probably you have to talk about it when you're talking about it. Does it make sense? I'm not sure. Hold on. Okay, and then.
What did you say again? Can you repeat it?
I forgot what I said. What was it about?
Just have you thought about it? It's not because of
Oh, okay. Oh, okay.
or not here at Johnson.
Oh, and a previous attempt of suicide is the highest risk factor. Oh yeah, that's it. Yeah. Am I missing a lecture? Is there another?
5 minutes left. 69.
16. Okay, let's see. The questions were going to be about the research. So what's missing in this research study or something? Let me just go through the lecture. Alright. Oh, and the main thing you have to go off is autonomy. So autonomy trumps everything. So if a patient doesn't want something, even though it's going to save his life, you don't do it. So autonomy trumps everything. And then what's next is, like let's say he's not able to make a decision, the next best thing to do is non-resistance. So autonomy, and if he doesn't have autonomy, non-resistance. Like that's pretty much this straightforward. Oh, this one. The definition. These definitions: disclosure, understanding, voluntariness, competence, consent. If you never give someone a referral, if someone refuses treatment, you have to follow them. I think the question about research. Oh yeah, so the vignette I had was like something about research. It gave like all these definitions and asked what is missing. So you have to know like you need all these for informed consent. And yeah, okay, cool. Any questions? Yeah, that's really it. Did I get all the
What
lecture?
did you say about referrals, you know?
You never give a referral.
Never give
For
a referral.
for just like, you know,
Just for the answer.
for like all of us, you never give a referral. For the means. Or staff. You never give a referral. But you do it in real life, but not in medical school.
Like I don't know if you
Hmm?
need it there. Like, I don't know.
It's a trap.
Okay.
Referrals are traps. But like you still use them in real life, so I understand. Okay. Oh, and what is it? You can only report child and elder abuse. Domestic abuse, you do not report it. And you have to report patients at risk for suicides when they're a threat to other people, like they have the plague or something. Oh no, that's risk for public safety. If the patient threatens to like hurt someone, or if the patient has a plague. So these are the incidences where you can report them. Child or elder abuse, when they're about to commit suicide, when they threaten someone else, and then when they have like a threat to public safety, so they have like the plague. Okay. Any questions? Okay. Just sign in before you go.